Well, I have a special treat for all of you. Director of our fellowship program, our cath lab, Dr. Neal Kleiman, who knows more about platelets than anybody else in the world. He's going to teach us more about antiplatelets. I know it's on everybody's mind. Dr. Kleiman?
Thanks, Alpesh. Raise your hand if you're a resident or fellow. Don't be embarrassed. Okay, none. Well, that's really too bad, because there's going to be a really important lesson here for residents and fellows, and that's this. I came here with 2 thumb drives, neither of which had my slides. I ran back to my office, got the thumb drive that was supposed to have my slides. It didn't, so I'm going to treat you to a talk without slides. And wait. So the lesson, if you're a resident or fellow, is don't ever agree to give a talk that you don't thoroughly know, because, yeah, but it's not a joke. So if you're left without audiovisual aids, you're probably better than if you use the slides. So, and it's easier to stay on track. So before we go any further, so I want everyone to imagine for a moment that they're God. Bill, I know that's difficult. Imagine that you're not God, but for the rest of us, imagine that you're creating an animal, and you got to keep the thing alive. So what do? Well, you have a circulation that delivers nutrients, removes wastes, clears them, and then you've got to protect that circulation against all the things that threaten it. So how do you do that? Well, it'd be great if you actually had someone or something that could get to a site where a blood vessel were damaged, get there real fast, manage to stay there, manage to call in the reinforcements, and then actually start treating that bleeding. And that's exactly what platelets do. When I was in medical school, we were taught platelets form the first layer, and that's their job, end of story. In the decades since that time, we've learned otherwise. And platelets really act like a fire chief. They get to the scene first, they do what they can, whatever is necessary, and then they call in reinforcements through a variety of really complex signaling mechanisms. So what we've learned to do since about 1973 is to try to modulate that response so that it works to our advantage, meaning this: we're not designed to live past age 30. Our vessels are not designed to develop atherosclerosis, but they do. And the result is sometimes they send out false alarms, get the fire engines in there, when in fact that becomes destructive rather than constructive. So antiplatelet therapy, as we know, it's an attempt to modulate that response. And everything that you and I are going to have to do with regard to antiplatelet drugs is going to be to match the clinical scenario, the risk of bleeding by knocking out platelet function too much versus the risk of not knocking out platelet function. In other words, the ischemic risk the patient has. So let's start with stable angina, stable coronary artery disease, which is what we see most frequently. And you'd think that we had the clearest answer for that situation, and we don't. We know that in patients who are at risk for coronary artery disease but don't have established coronary artery disease, there's a very fine line between benefit and risk of even treating someone with an aspirin a day. So it's one of the 2 most common questions that patients ask. Should I be on aspirin? Well, the answer so far, at least this year, is pretty straightforward. If you don't have established coronary artery disease, if you haven't had an MI, if you haven't had a stent or, God forbid, a bypass, and you don't have a clearly positive ischemic study, the answer is no, you shouldn't. Because in that population, Carlo Petrono, the king of aspirin therapy, has worked out the risk-benefit ratio. And the number needed to treat to prevent an event is somewhere between 500 and 1,000. The number needed to harm is about 100. So you have to treat 5 times as many patients to prevent one event, as you would cause an excess event. Now go to the other end of the spectrum. Unstable coronary artery disease. There the numbers are about the opposite. Number needed to treat is about 100. Number needed to harm, somewhere between 500 and 1,000, depending on the acuity of the illness. So really simply, primary prevention, no established disease, no aspirin. Established disease, we're probably in the gray zone. All the guidelines tell you to treat with aspirin. If a patient asks you, should I be on aspirin? I had a heart attack 6 years ago. The answer is yes. Now, the second question that every patient asks is, how much aspirin should I be on? Should I be on a baby aspirin? Should I be on half an adult aspirin? Should I be on an adult aspirin? Should I be on 4 aspirin a day? So far, based on data that are kind of soft, it looks as though the aspirin dose that you should be on is a baby aspirin a day. It may take a little longer to be activated, but we're looking at chronic therapy in a low-risk group of patients. 81 milligrams a day is sufficient. There is, as of 2018, no indication for a patient to take more than a baby aspirin a day. And in fact, the only thing that increases with increasing aspirin dose is the bleeding risk. And when we talk about acute coronary syndromes in a moment, if you're treating a patient with ticagrelor, that is Brilinta, then the use of a full adult aspirin is contraindicated. And in one of the 1,001 regulatory measures that we measure up to, you get an X rather than a check mark if you give a patient on ticagrelor 325 a day. So 325 milligrams of aspirin is great for headaches. It kind of works for backaches sometimes. For cardioprophylaxis, forget it. What about dual antiplatelet therapy? Aspirin plus a second drug, one of the P2Y12 antagonists. There are 3 such drugs. Clopidogrel or Plavix, drug that's been around for about 20 years. You all have some familiarity with it. 2 newer drugs, Prasugrel or Effiant, ticagrelor or Brilinta. So far, with the one exception that we will, again, come back to, is if you have coronary artery disease that is not acute, there isn't an indication for a second drug. That's shown in a large trial done about 15, 20 years ago, known as Charisma. No benefit in patients with stable coronary artery disease for dual antiplatelet therapy, with the one exception that we'll come back to. What about acute coronary syndromes? Now we're talking about a more active thrombotic system, higher risk. So what we used to call unstable angina, non-STEMI, and ST elevation MI. There's a clear indication for dual antiplatelet therapy, aspirin plus a P2Y12 antagonist in those patients. Patients with a recent coronary stent, hands down, every one of those patients should be on dual antiplatelet therapy. How long? Well, the CURE study done in 2000 showed that aspirin combined with clopidogrel led to a significant reduction in the risk of death, myocardial infarction, or stroke when patients were treated for 15 months. So that's become the gold standard for minimal duration of dual antiplatelet therapy after an acute coronary syndrome. Now, what about 16 months? What about 3 years? What about 5 years? We don't know. But if someone has had an acute coronary syndrome, there probably isn't a reason to take them off dual antiplatelet therapy. Now, among the P2Y12 antagonists, the so-called ADP receptor antagonists, there are 3. Clopidogrel, been the standard drug for about 20 years. Prasugrel and ticagrelor have been out close to 10 years. Those are called second-generation P2Y12 antagonists. They're different. Clopidogrel is metabolized in 2 steps in the liver. That means its onset is slow, really slow. Take a single clopidogrel tablet, it takes 24 hours to work. Take 8 clopidogrel tablets, they reach their peak effect in between 4 and 6 hours. What happens if you take 200 clopidogrel tablets? Anyone know? Takes between 4 and 6 hours. They're bottlenecked in the liver. If you're feeling really bad and you want to go home and take a bottle of pills, don't take clopidogrel. Or maybe take clopidogrel. You will wake up in the morning. It'll be no different than if you took 8 tablets. You will end up with expensive feces, though, so think of that, and you'll be alive to have to pay it off. There are patients who have defects in the enzymes that metabolize clopidogrel. We call them clopidogrel resistors. In Caucasians, about 25%, East Asians, close to 50%. There are a variety of tests available to test sensitivity to these drugs. You can take a blood sample and very quickly get it turned around, see if the patient's responding or not. And you would think if they don't respond to clopidogrel, maybe you should use one of the newer drugs that is not dependent on those same enzymes to become activated. Well, the sad truth is there are now 4 trials, all of which are flawed, but none of which show a benefit to that approach. So right now there isn't an indication for bedside testing. The other thing about clopidogrel is we frequently see it stopped when someone's coming to the cath lab. Don't stop it. If we're going to cath someone with a possible PCI, we want them on it. There's a benefit to being on clopidogrel if you're getting a stent. There's a benefit to having it beforehand. Prasugrel, the second drug out. Also metabolized in the liver, different enzymatic pathway. The rate of resistance is much lower. It inhibits platelets more profoundly. It's indicated only in patients with an acute coronary syndrome who are having a PCI or who are STEMI candidates in whom you're looking to do a PCI. So no PCI, no prasugrel. Prasugrel also has a boxed warning from the FDA. Patients with prior stroke or TIA, patients who weigh less than 60 kilograms, or patients less than 75 years old have a boxed warning, which means the FDA has said to the manufacturer of prasugrel, don't use it in these patients. Actually, over 75, they've recommended reduce the dose from 10 milligrams to 5 milligrams. But remember the boxed warning. Ticagrelor, also a P2Y12 antagonist. It's direct acting. In clinical trials of patients with high-risk ACS, prasugrel and ticagrelor were superior to clopidogrel when combined with aspirin. And the other thing about the prasugrel, or rather the ticagrelor trial, is there was a reduction in cardiovascular mortality. The other easy to remember thing about using that particular drug is it's indicated for patients with a high risk ACS, whether they're going to the cath lab or not. So easier to remember whether you can or can't give that drug. It doesn't have a boxed warning. Now, whether that's because one drug got lucky, one got unlucky, or maybe both should have it, maybe neither should have it, I don't know, but that's the way it is. Things you have to be wary of with ticagrelor. It can cause AV block in patients who have pre-existing high-grade AV block. It can make it worse. It can cause bronchiolar spasm that turns out not to be harmful, but is troubling. And if you get called at night, someone was recently started on ticagrelor and they're getting dyspneic, if they don't have LV dysfunction, probably the first thing to do is stop it and switch them back to clopidogrel. So I got 1 minute, 15 seconds, the second half of my talk. So the next 90 minutes, I'll talk about how long. So the answer is we don't know. There, as of 2016, were 16 randomized trials in patients who got stents of short, meaning less than 3 months, versus long, meaning 3 to 12 months duration DAPT. 16 trials, 45 meta-analyses. So that means 45 people were told by their chief of cardiology, you haven't published enough. They went back, scratched their head, said, I'll do a meta-analysis. None of the meta-analyses agree. We still don't know. I haven't rechecked the literature. I guarantee there are probably 90 meta-analyses now. Here's what you take home. The truth is, in first 12 months, short versus long, the duration of DAPT probably is dependent on vessel-related factors, complex stenting versus non-complex stenting. The more complex the stents, the greater the indication for prolonged DAPT within the first 12 months. If you look at the trials of short versus long DAPT, they're almost all simple stents. So people are lying to you. Most patients probably, I'll put my neck on the line here, probably require 12 months of DAPT. What about beyond 12 months? There is one trial known as the DAPT trial. It's the best of all these duration trials. It's a little unclear. 12 months versus 30 months of DAPT. Turns out vessel-related factors didn't predict who benefited. Patient-related factors did. So if you balance the risk of bleeding versus the risk of thrombosis, there is an index that's been developed, and there's an app for it, so you don't have to calculate it. It's called the DAPT index. And very simply, it tells you that patients who have baseline anemia, patients who are older, et cetera, have a higher risk of bleeding and less likelihood of preventing thrombosis. So keep that in mind. Someone's young and strong and vigorous like me, prolonged DAPT. Someone's old and feeble and all that, like I used to be, 12 months of DAPT. So one parting word, what about the 7% of patients who in every study have atrial fibrillation and need a stent? What do we do with them? Those data are still unclear. Right now, every randomized trial, and there are 3 done, and they're all not quite adequate, but they all tend in the same direction, and they show you that dual therapy, meaning patient needs an anticoagulant, you keep them on that anticoagulant, and you add a P2Y12 antagonist, usually Clopidogrel, ticagrelor has been studied too, but a P2Y12 antagonist plus the anticoagulant. No aspirin. Any questions? No aspirin. What comes before aspirin in that situation? Alpesh, you're a smart guy. What word comes before aspirin? Yeah, the word no. That's what we have now. And then the other thing that's really good. And then the other thing I told you we'll talk about, we're out of time, is there is a population of patients who've had remote MIs who turns out probably benefit from aspirin with a low dose of ticagrelor, but we can talk about that another time. Thanks, Alpesh.